morning, everybody. Thanks for being with us. Today is Wednesday, February 17th with our next installation. I will say that we started these video talks back in March of 2020. It was at the time a quick means of getting factual information out to everybody about COVID. And now here we are. This is our 20th video. We seem to be stuck on the same theme of COVID. We haven't been able to move on and just use this mode of communication for other means. So today I have a guest. We can finally afford guest speakers. So today I have a guest, Shawn, of course, runs our respiratory clinic and our same-day care. And lest you forget, we're in a pandemic. We've been talking about vaccine, but there are still people getting ill. So Shawn's going to talk to us about testing, something we kind of stopped talking about a month ago. So Shawn, what's new?
Gary, thanks for having me today. So today I'd like to talk about a new point-of-care test called the Lucira test. The Lucira test is unique and it's really exciting for us because we finally have a point-of-care test for COVID. This test is a single-use disposable point-of-care test, and it was granted under an FDA emergency use authorization in November of 2020. And the key thing here is it replaces the Sutter Shared Lab PCR test, and it can be run by a medical assistant, an LVN, or an RN. And we are one of the test pilot sites. We're up here in Santa Rosa. There's 2 sites in San Francisco. And this is a joint venture between Lucira and Sutter that studied this. So it's really exciting that we're part of this. 3 things that are important about this test is that, number 1, it just decreases the patient's notification time to get the results from 2 to 4 days to under 24 hours. So this is huge for us clinicians. It's great for our patients. It also just decreases the burden on the Sutter Shared Lab so they can work on other projects. And then the final thing is that working with Dr. Green, we're looking at using this and incorporating this into identifying patients that can be used for or be given monoclonal antibody therapy for COVID. So this will be part of that process. So the way it works is it's called reverse transcription loop-mediated isothermal amplification. It's a long word, but it's basically, it's looking at nucleic acid, RNA, and it's similar to PCR except for one major step, and it doesn't require the thermal cycler. And what that means basically is you don't need expensive gear, it's more time efficient, and people who are not lab techs can use this. You basically gather the sample, put the Q-tip inside the little container, swirl it gently 15 times, and then you have a result in under 30 minutes. So there's questions about performance with any point-of-care test, because as you know, there are other point-of-care tests that we've been looking at over the past several months, and none of them really met the sensitivity or specificity that we all thought that would be sufficient or safe for our patients. This test actually is the first point-of-care test that has a high sensitivity and specificity. And when it was looked at by both Lucira and Sutter in some studies, they found that it had a sensitivity of 94.1% and a specificity of 98%. It's been looked at small population samples as well, and that's been validated with a Sutter down in the Bay Area as well as Lucira. Now there's important caveats to this test. Number 1, you should not use it on asymptomatic patients. Both Lucira says that as well as the EUA from the Food and Drug Administration. And the other thing to think about is the epidemiology of this, which is the positive and predictive values will vary depending upon the disease prevalence. Meaning, if you have a low prevalence of disease, you may have some false positive tests. But when you look at a screening test, that's okay, because I'd rather have a few false positive tests than a few false negative tests. So Sutter and Dr. Green, we all feel that this is the right way to go for us. So finally, just a couple points. This is the first point-of-care test that we're rolling out in the Sutter SBMF footprint. It's for symptomatic adults and pediatric patients only. A key thing here is that patients who are COVID positive in the prior 90 days should not use this test because there's going to be a high incidence of a false positive. And then finally, we're going to ask that patients are going to receive the results from the respiratory clinic within 24 hours. It's true that the test, we can get the results back in 30 to 60 minutes, but from an operational viewpoint, it's going to help our medical assistants with the staffing crunch that we're just messaging to patients that you're going to get your result by the end of the day or at least within 24 hours. In most cases, they're getting it by the close of business. And the final question everyone's going to ask is, do we have enough of these devices? And the answer is we currently do, and we'll just see how it goes. So that's it, Gary.
Good. Shawn, I have a question about workflow. So for those of us who are referring patients to get tested, there was a time when we would kind of do a video visit and then just send them over for test only. Are we using that, or are we now referring everybody to the respiratory care clinic to see a provider?
For the time being, we've asked that patients be referred to a provider to have testing as well as an assessment. There's a couple of reasons for this. One of the main reasons is just we don't have the staffing to have the LVN out in the tent anymore.
Okay. So only symptomatic patients and only the respiratory care clinic at this time.
Correct.
Great.
All right.
Shawn, thank you.
All right. Thanks, everyone.
So we're going to move on to some different topics in COVID and start talking more about the vaccines. So before we go on to our next guest, I just wanted to show you the most recent smart set that's come out that if you review it, you'll find it's actually very helpful and pretty comprehensive. It's COVID-19 vaccine reaction. So as you go in your smart phrases, there are now innumerable COVID-19 smart phrases. This one's very good for your patients who are calling with side effects to educate them and try to defer those calls coming in. So back here with Gary, again to talk about the things that are on our mind. You know, we try to hit and address topics that you might see on the front page of the paper, which means your patients are seeing it and asking you questions. And the vaccines are still the name of the game. Of course, the biggest thing on the front page is probably the shortage of vaccines, and we'll get to that later. But Gary, let's talk about vaccines. And the one thing that is very topical is the variants. As we see, they're popping up all over. And I have a process question. Who defines a variant? How do you look for variants? Because when we're in a flu epidemic, I don't really hear so much about variants popping up.
Yeah, so worldwide, as well as nationally, there's something called the FluNet. And the FluNet is a number of laboratories that follows the influenza season, and they sequence a virus every year. And that happens internationally. That's why we know the virus can change in Australia, can change in New Zealand, and we change the vaccine up here. So now there's this thing called COVIDNet. COVIDNet is an international conglomeration of laboratories. Now in the US, those represents government laboratories like CDPH, public health laboratories. It also represents some commercial laboratories, as well as academic ones. Like in California, Scripps Hospital, Scripps Lab, as well as UCSF is participating in the COVIDNet. And what we do is we take the virus and we sequence it, and we look for change in the mutations in the mRNA. Based on those mutations in mRNA, the virus adapts, it changes, the conformation of the glycoprotein changes, and that leads to different characteristics of the virus. That's a worldwide thing, and right now, the CDC's goals are to test at least 1%. At least 1% of the viruses that are confirmed, we want to test them for any new mutations, and we're going to find variants, we're going to see variants. The virus does mutate, it doesn't always check its mutations, and most of those mutations end up in a deleterious mutation, which means the virus can't survive.
Okay, so what are the significant variants we're dealing with today?
So there's two ways to look at that. What's happening on an international scale, and then what's happening on a national scale.
Okay.
I'm going to show a couple slides internationally. So this first slide comes from the World Health Organization. This is like a weekly update, and it shows 3 specific columns and 3 specific international variants. The first column is a B117 strain, and that came out of the United Kingdom. Now, first of all, I'll back up a little bit. We're dealing with a strain right now. Early in the pandemic, when the virus spread out of China and it went to Italy, a mutation happened. And we're seeing that variant right now. We're not seeing the original virus out of Wuhan, China. We're seeing the virus as it mutated out of Italy. And we talked about that 6 months ago. And so now we're tracking 3 new variants on the scene. The B117 is one of the UK. That one's got a lot of notoriety because that variant seems to be the one that maybe have slightly more virulence. And that's some epidemiologic data that's been put on the internet by the government of the UK. The middle column is the South African variant. And the South African variant, B1351, has got a lot of notoriety because the AstraZeneca vaccine and the Johnson & Johnson vaccine were compared to people who recovered in South Africa. And it seemed like the vaccine was 15% less effective in South Africa. But that doesn't mean the Moderna and the Pfizer vaccines are. We don't know that yet. And then the third column here is the one out of Brazil called the P1. It's kind of the nomenclature that everyone's been talking about. B1128 is also the lineage. And so we're tracking that. So let me show you the maps. Right now, this is the UK strain, B117. This is where it is in the world. It's in over 40 states in the US. We've seen more than 1,200 cases in the US. This is a South Africa strain. We think that the South Africa strain is much more contagious than the UK strain, but that's being worked out right now. And this is the P1 strain from Brazil. So these are the 3 world maps in the World Health Organization because there's this international effort, this COVID-net effort to track the viruses.
Okay. So COVID's COVID still. I mean, when a patient presents they're ill, you still treat them all the same way without use of the variants. So what are we doing with this information? Are the manufacturers of vaccines doing anything different with this information?
Yeah, so first of all, we have to test the viruses against people who have survived from natural infection and also people who have gotten the vaccination. So those are very different because some people with natural infection can get reinfected with a different strain. And so it's better to be vaccinated than to go through natural infection. And that's why people who get through natural infection need still to be vaccinated to protect them from reinfection from a new strain.
Okay.
Now, I know that Moderna and Pfizer are actually making a new virus built in with a variant because they want in the vaccine. So Moderna and Pfizer vaccines are trying to make a booster should we need it. We don't know if we're going to need an additional vaccine for a new variant, but if we are, those companies are preparing that and doing the research right now on that.
And that's probably down the road sometime, I imagine. So.
Yeah, I imagine that would be, if we did a booster shot for a variant, would probably be towards the end of this year, if it's necessary at all.
Okay, more to come on that, I'm sure. Let's talk about side effects, because the big fear of people was that these vaccines were developed too quickly without, adequate supervision or, knowledge of what potential side effects. Now we're 2 months of vaccinating people. Have you seen any statistically significant side effects? Well, I have an uncle that we know about who had this or that, but anything on the horizon that we should know about?
Yeah, so the take-home point with the vaccines is they're remarkably safe. We're safer than they thought they would be. We really expected to have like the 1976 influenza vaccine, which ended in Guillain-Barré cases. We're not seeing that with this vaccine. And it's good because as healthcare workers, we can demystify that we rushed this vaccine. This vaccine was developed in 2009. We know this vaccine. We've dealt with this vaccine. The NIH and other vaccinologists have a lot of information and a lot of experience with this vaccine. We've just never needed to use it in a season like a pandemic. And so it's important for us to communicate to our patients that we didn't rush this vaccine. We've had this on the shelf for 10 years. The other thing about the vaccine is that it's remarkably safe. It's more dangerous to get natural infection and try and survive that than it is to get vaccinated by a factor of 100. It's amazing. So if you look at vaccine reactions at less than 1 million, we've seen a little bit of a signal. So in the early trials, we saw that there was a little bit of Bell's palsy. We're not seeing that very much. It's just anecdotally. And so far, to my knowledge, less than 1 case in 1 million. The new thing is that there could be some thrombocytopenia. But we've had 55 million doses of vaccine in the US given out, and we've seen less than 40 cases of ITP or thrombocytopenia. So less than 1 in 1 million. So I think less than 1 in 1 million chance of a vaccine reaction is much safer than trying to survive the vaccine, where in certain population, it can be up to 10% mortality.
So this is real relevant when we're talking to patients. So everything's a risk-benefit analysis. So what we're doing is talking about the risk of the vaccine versus the risk of getting the illness. What can you talk about the risk of the illness? I mean, what's mortality if you're hospitalized, those kind of things?
Yeah, so if you're over 80 and you're hospitalized, it can be up to a 25% mortality.
Okay.
And we see that in our hospital when patients get admitted and they're in the higher age group or with comorbid things like diabetes and liver failure and cirrhosis. It's like a 1 in 20. It's like a 1 in 4, 1 in 5 chance that they might not pull through. All comers, it's about 0.1, 0.1%. And kind of honestly, I wouldn't want to be in that ballpark of I'm just going to see how I do with natural infection. And natural infection isn't as good for preparing yourself down the road than it is for vaccination. So vaccination gives you more of an immune response. The other thing we don't talk about a lot, and we're going to talk about soon, are long haulers. People who survive the virus, people who get through a really severe hospitalization, they have trouble on many fronts. Cognitively, neuropsychiatric side effects. I've seen seizure disorders from that. This whole element of dyspnea, brain fog and fatigue. So surviving the virus for some people has really been a long haul. In our hospital, we've actually had one case of BOOP, or now that's called COP, right? Bronchiolitis obliterans organizing pneumonia. Someone got readmitted, which looked like COVID. It wasn't a reinfection, it was an immunologic response to getting through the virus. So you can avoid that whole long hauler thing if you do survive by getting vaccinated.
Okay.
So having natural infection in this instance is not safer at all.
So the punchline is, in this evolving scenario, the risk of the vaccine is far less than the risk of infection.
Yeah, I think the
Look at
risk
all
of
this.
a serious vaccine reaction is less than 1 in a million.
Okay.
And that is incredible. We never thought we'd have that safety data with this vaccine.
Great, thanks. So the other thing that's on the front of the paper frequently and a lot is the erratic or short supply of vaccine. And I just wanted to bring that locally. We are feeling that at Sutter and here in Santa Rosa. So we are getting somewhat of an erratic supply, which unfortunately has forced us to shut the Luther Burbank site, at least today. We're not vaccinating patients for lack of vaccine. Tomorrow, the Luther Burbank site will be resuming with the second dose now. We're starting on the second dose of Moderna for our patients that came through weeks ago. But just so you all know, we're all on the same page, the vaccine supply has been erratic, as it has been throughout the nation. And that's not only going to affect vaccinations, but you're going to see that in your staffing too. So when the COVID clinic is closed, you're going to have some staff back, and they might be gone the next day. So just bear with all of that. We're still able to do pretty well with our Stony Circle and our airway clinics. The staffing, we know that staffing's been challenging, and it's going to continue to be challenging throughout this epidemic and the vaccination phase. But we had talked previously about new recruits coming, new hires that are trained specifically to work in the vaccination clinics. They're starting to dribble in now, and we're told that by about March 1st, we should really be feeling that relief from them. And so our staffing in the clinics is probably at its worst right now, and we hope everything will be getting better. So that's what we have to say. One other thing I want to point out is that you might have received an email, you did receive an email about a new digital screening tool where you can self-screen yourself, and we're going to eventually substitute that for having screeners at the door for our providers and our employees, not for our patients. So you might want to familiarize yourself with that app, and then next week we'll be rolling out how we're going to use that. So the last thing I would say is we're here to kind of answer your questions. So we're always looking for topics that you would find most helpful in dealing with your patients. So feel free to give us a shout if questions come up that you want us to address.
Yeah.
So, all right, thanks, Gary. Have a good day.